between the layer of fascia. These are normally filled with loose connective tissue, which readily breaks down when invaded by infection, and various anatomical structures like vein, arteries, gland, lymph nodes, etc. Actually, the space is a misnomer as there are no voids in the tissue in actual reality. Even though it is called a space infection, there is no any space within the maxillofacial region. Okay, it is a misnomer. The space is only created once there is infection. Whenever there is infection, there will be accumulation of inflammatory fluid, and it will split the normal loose irregular tissue, and it will lead to accumulation of inflammatory fluid, and in late cases, it may lead to formation of pus. So the facial space infection is itself misnomer. There is no any space in reality. In normal condition, there is no any space. It is filled with loose irregular tissue. It consists of artery, vein, and other anatomical landmarks. So moving to classification of facial spaces, depending on mode of involvement, it is of two types: primary spaces and secondary spaces. If the odontogenic infection directly involves those spaces, those are known as primary spaces. If the odontogenic infection does not directly involve those spaces and which are involved secondarily, after once the primary spaces are infected, if you don't treat them, it will again enter into the nearby neighboring spaces. Those spaces are known as secondary spaces. Again, in primary spaces, there are maxillary spaces and mandibular primary spaces. So in case of primary space, in maxilla, there is canine space. It is also known as infraorbital space. There is buccal space and infratemporal space. In case of mandible, there is submental space, buccal space, submandibular space, and sublingual space. So the most common space infection in maxillofacial region is buccal space infection. So buccal space infection is the most common space infection in maxillofacial region due to odontogenic infection. Okay, buccal space infection may happen either due to maxillary teeth or mandibular teeth. Secondary facial spaces are, there is something called masticator space, there are submaxillary space, pterygomandibular space, temporal space. Temporal space is again divided into superficial temporal space and deep temporal space. It is called masticator space because those spaces are associated with muscles of mastication. As these spaces are associated with muscles of mastication, they are known as masticator space. There are 4 types of masticator space: maxillary space, or it is also known as submaxillary space. It is present between the maxillary muscle and lateral surface of ramus of mandible. And there is pterygomandibular space. Pterygomandibular space is present between the medial surface of ramus and medial pterygoid muscle. Superiorly, there is lateral pterygoid muscle. Okay. Similarly, temporal space is present above the zygomatic arch. It is divided into 2 types: superficial temporal and deep temporal space. Superficial temporal space is present just above the temporalis muscle, and the space which is present below the temporalis muscle is known as deep temporal spaces. On the space is lateral pharyngeal space. Lateral pharyngeal space is present on the lateral side of the pharynx. It is present between the medial pterygoid muscle and superior and middle pharyngeal constrictor muscles. Posteriorly, it is continuous with the retropharyngeal space, and anteriorly, it is continuous with buccal space. Next is retropharyngeal space. It is present in the posteriorly. Okay, posterior to lateral pharyngeal space, there is retropharyngeal space. The anatomical structure which divides the lateral pharyngeal space with the retropharyngeal space is carotid sheath. The space interior to the carotid sheath is known as lateral pharyngeal space, and the space which is present posterior to the carotid sheath is known as retropharyngeal space. Then there is prevertebral space and parotid space. Parotid space consists of parotid gland. There is something called as fascia, superficial fascia, and deep fascia. Deep fascia again divided into 3 types, 3 parts: superficial part, middle part, and deep part. Okay, these fascia splits and form the parotid space. And parotid space consists of parotid gland, and within the parotid gland there is presence of facial nerve. All the terminal branches of facial nerve are present within the parotid gland. And that the space found by those fascia are also known as parotid fascia. Now, if you see the stages of infection, any infection proceeds through these 3 stages. The initial stage is known as edema stage or inoculation stage, followed by cellulitis stage, and the last one is abscess. Finally, it will form pus and it is known as abscess. So duration is the inoculation stage varies from 0 to 3 days. Cellulitis stage varies from 1 to 5 days. And abscess formation takes place from, it takes around 4 to 10 days to form the abscesses. So it depends on pathogenicity of the bacteria as well as immunity of the individual host and the anatomical structure where the infection is present. Pain and borders in case of inoculation stage, the pain is mild and the border is diffuse. In case of cellulitis stage, the border is not definite. There is diffuse border. In case of abscess, the border is localized. There is presence of pyogenic membrane. So most painful condition is cellulitis stage because it is in spreading stage and patient will have severe pain if the infection is in cellulitis stage. There will be all over the area there will be huge inflammation and patient will have severe pain. Size is variable in case of inoculation stage. It is large in case of cellulitis and it is smaller in case of abscess because the pus is confined within the pyogenic membrane. And whenever there is pus, the one and only treatment is you have to drain this. Okay. Never prescribe antibiotic when there is presence of pus. You have to drain the pus first, followed by antibiotic, because the cellulitis and abscess are present together. In the central region, there is presence of abscess. It is surrounded by the cellulitis. So in case of cellulitis, you have to prescribe the medication. You have to prescribe the antibiotic. If there is pus, you have to do incision and drainage. Anyhow, you have to remove the pus. Because whenever you prescribe the antibiotic will not enter into the pyogenic membrane. The antibiotic will not reach to the area of pus. So you have to drain it. The color is normal in case of inoculation stage. It is red in cellulitis, and in case of abscess, there is shiny center. Consistency is jelly-like in case of inoculous edema. It is board-like, hard in case of cellulitis. There is soft center in case of abscess. Progression is increasing in case of inoculation stage. It is increasing in cellulitis as well, but in case of abscess, once the pus is found, once there is necrosis, it will decrease. Pus is absent in case of inoculation and cellulitis stage. It is only present in case of abscess. Bacteria is, initially there is aerobic bacteria, then there will be mixed infection followed by anaerobic bacteria. What happens in the initial stage, whenever there is presence of oxygen, the aerobic bacteria will grow. It is very interesting phenomenon. And what happens once the infection has spread in the deeper tissue? In deeper tissue, the availability of oxygen is not there. There is hypoxia. So in hypoxic environment, the aerobic bacteria could not grow. In such environment, only the anaerobic bacteria grows and all the aerobic bacteria will die. So in deep infection, there is presence of anaerobic bacteria. In the superficial infection, there is presence of aerobic bacteria. So it is started by aerobic bacteria. Later, once it reaches the deeper structure, there is hypoxia. The oxygen is not there. In such environment, the aerobic bacteria could not grow. So there will be growth of anaerobic bacteria. Seriousness is low in case of inoculation stage. It is greater in cellulitis, and it is again less in case of abscess. Another thing you must understand in case of abscess infection or pus in the case of maxillofacial region is, in case of other part of the body, whenever there is pus, you have to give incision and drainage at the most prominent part. Okay, you have to drain the pus, but in case of maxillofacial region, never try to puncture or give any incision from the most prominent part, because the tissue is necrotic, and once it is healed, it will form unsightly scar. The aesthetic problem is there. So in case of maxillofacial region, you have to always give the incision from the healthy skin. In the dependent part from the healthy skin. Let's say if there is buccal space infection, as you know, the buccal space infection is more common. If there is accumulation of pus, never try to give the incision in the more prominent area. You have to give the incision in the healthy skin and dependent part. It's better to give the incision near the lower border of the mandible. Okay, so that due to gravity, the pus will drain, and you have to always give the incision in the healthy skin in maxillofacial region. That's the difference between the maxillofacial region and other part of the body. In other part of the body, whenever there is the accumulation of pus, the incision is given, or stab incision is given just above the most prominent part of the cavity. But in case of maxillofacial region, you have to always give the incision in the healthy skin, never above the necrotic part, because the tissue is in necrotic stage. It will heal by secondary bone healing, and it will lead to thick scar formation. So it will produce unsightly scar. The aesthetic problem is there. So you have to always give the incision through the healthy skin. and you have to give the insulin the dependent part, so that the pus will be drained by gravity. So signs of infection are: there is rubor or redness. It is due to cutaneous surface involvement due to vasodilation effect of inflammation. There will tumor or swelling occurs due to accumulation of pus or fluid exudate. Calor or heat is the result of increased blood flow to the area due to the vasodilation. These all are the features of inflammation. Whenever there is infection, body will produce inflammation as well. There is dolor or pain results from pressure and sensory nerve ending from the tissue distension caused by edema or infection. And finally, there will be loss of function. There will be problem with mastication, trismus, dysphagia, and respiratory impairment. Now, spread of infection from the upper incisors. The most important rule is, you must understand, is infection always travels through the path of least resistance. Whenever there is least resistance, the infection will follow that path. In case, let's say, if there is periapical infection in the upper central incisor, let's say if it is carious, if the patient has not undergone treatment, it may involve the pulp. Initially, it will involve the coronal pulp, then followed by radicular pulp, then followed by periapical infection. Still, if the patient does not get any treatment,
I don't have an answer for that. Is there something else I can help with?
So if there is periapical infection and patient has not gone any treatment, then it will spread. Now, the upper central incisor may lead to vestibular abscess or buccal space infection, or it may lead to palatal abscess. That depends on the angulation of the teeth and the thickness of the bone. Okay, let's say in the first case, there is periapical infection, and if you compare the thickness of the bone, the cortical bone and the palatal bone, the considerable, if you see the thickness, comparatively the labial plate or labial plate is comparatively thinner than the palatal plate. So the bone which is present palatally is more dense. The thickness is more, so the infection can easily spread to the buccal cortical plate. It can easily perforate the buccal cortical plate. Okay, so it will lead to vestibular space infection because the angulation of tooth is such that there is very less amount of bone is present on the buccal surface as compared to palatal surface. Okay, as the very less amount of bone is present labially as compared to palatally, so the infection will drain into the, it will cause perforation of the buccal cortical plate, and it will drain all the pus in the vestibular region, and it will lead to vestibular abscess. Okay. Similarly, again, if the angulation of the tooth is like this, and if the amount of bone present in the buccal cortical plate is more as compared to palatal plate or palatal bone, so the perforation will take place on the palatal side and lead to palatal abscess. So the infection can spread to anywhere. It may perforate the buccal cortical plate or palatal cortical plate. It depends on the thickness of bone and angulation of the teeth. If the teeth is more vertical, the buccal cortical plate will be thin. So periapical infection will drain into the buccal cortical plate. It will cause perforation of the buccal cortex. If the angulation of the teeth is more, if it is treated, then in such cases, if the palatal bone is thin, buccal cortical plate is thick, in such cases, it will cause perforation of the palatal bone and it will lead to palatal abscess. So it depends on the resistance of the bone. Infection always travel through the path of least resistance. Spread of infection from upper molars. Another thing, you have to see the muscle attachment as well. Let's say if there is infection upper distobuccal tooth of maxillary first molar. Now what will happen? Whenever there is infection of the periapical region in the buccal root of the molar, then the infection again travels through the path of least resistance. Now, if the cortical plate is perforated below the attachment of bosinator muscle, the muscle here shown here is the bosinator muscle. Only the bosinator muscle is attached at the alveolar process. So, if the cortical perforation will occur below the attachment of bosinator muscle, it will lead to formation of vestibular abscess. If the cortical perforation takes place above the attachment of bosinator muscle, then it will lead to buccal space infection. So, whenever there is periapical infection in the buccal root of the molar region, then it may lead to either vestibular abscess or buccal space infection. So it depends on the thickness of bone length of root. Okay, if the cortical perforation, and also the attachment of most important thing is attachment of basilar muscle. If the perforation, if the cortical bone is perforated below the attachment of basilar muscle, then it will lead to vestibular space infection or vestibular abscess. If the cortical perforation takes place above the attachment of basilar muscle, then it will lead to buccal space infection. So the which space infection will happen, it also depends on the attachment of muscles. Now again, a spread of infection. See, there are multiple possibilities. Okay, if there is infection in the maxillary tooth, let's say, let's say maxillary premolar or maxillary molar, then what will happen? So the infection may spread into either vestibular abscess. It may lead to formation of vestibular space infection or buccal space infection. It may cause palatal space infection or palatal abscess, or the infection may spread into the maxillary sinus. It will lead to acute maxillary sinusitis. So it depends on the thickness of bone, as infection always travel through the path of least resistance. Okay, so it depends. If the bone present above the apex of the tooth and maxillary sinus is very thin, then it may enter into the maxillary sinus. It may lead to maxillary sinusitis. If the palatal plate is thin, okay, as compared to the buccal bone, in other bone, it will lead to palatal abscess formation. If the buccal cortical plate is thin, if the perforation occurs below the attachment, this is a basilar muscle. If the perforation occurs below the attachment of basilar muscle, then it will lead to vestibular space infection. If the perforation occurs above the attachment of basilar muscle, then it will lead to buccal space infection. So all are the possibility. If your molar or premolar tooth are carious, it may lead to either vestibular space infection or buccal space infection, or maxillary sinusitis, or it may lead to palatal abscess formation. Okay, so it depends on the thickness of bone and also angulation of the teeth. And the most important thing, the same infection will not cause multiple space infections. Let's say if there is a vestibular space infection, again it will not lead to palatal space infection or buccal space infection, because the same infection will not cause more than one perforation. Because what happens is, whenever there is periapical infection, there is due to presence of inflammatory fluid, there will be pressure, and then it will lead to pressure resorption. The size of the periapical infection will enlarge. So once there is either perforation in the buccal cortical plate, the pressure which is created within the bone will be released into the soft tissue. So there is no more pressure, and all the inflammatory fluid which are accumulated in the periapical will be drained into the soft tissue. Now the infection will travel through the soft tissue. There will be no more resorption, and once the cortical plate perforation has already happened, again now there will be no more resorption, and the other spaces of infection will not be there. Okay, suppose if there is palatal space infection, if there is palatal perforation, now it will not lead to either buccal perforation, it will not lead to either vestibular space infection or buccal space infection. Once the cortical bone has been perforated, once the infection has spread to the soft tissue, comparatively resistance provided by the soft tissue is comparatively very less as compared to bone. So now the infection will travel through the soft tissue. There will be no more bone resorption, and it will not lead to again another perforation. So there may be either vestibular space infection or buccal space infection or maxillary sinusitis or palatal abscess. Simultaneously, there will not be more than one infection due to the one reason. Similarly, if you see the mandibular teeth, let's say if it is a mandibular molar tooth, then again here it depends. If there is periapical infection, the infection will spread, and it will lead to either, if a cortical perforation is present above the attachment of this basilar muscle, again it will lead to vestibular space infection or vestibular abscess formation. If the buccal cortical plate is perforated below the attachment of basilar muscle, it will lead to buccal space infection. Now, lingually, if the lingual plate is perforated below the attachment of this is mylohyoid muscle, as you know, the mylohyoid muscle is attached on the lingual surface of the mandible. If the lingual plate is cortical plate is perforated below the attachment of mylohyoid muscle, it will lead to submandibular space infection. Similarly, if the cortical plate is perforated above the attachment of mylohyoid muscle, then it will lead to sublingual space infection. So there is a possibility that if there is periapical infection in the mandibular posterior teeth, it may lead to either vestibular space formation or buccal space infection or submandibular space infection or sublingual space infection. All are the possibility. That depends on the anatomy. the angulation of the tooth, the thickness of the bone, and infection always travels through the path of least resistance. Where the bone is thin, it will create perforation on that side. And once the infection has spread to the soft tissue, now there will no more bone resorption, and the infection will travel through the soft tissue. So the primary spaces are involved. If the patient is not treated, then it will again enter into the secondary spaces. Now it is a case of palatal abscess. It is due to carious first premolar. The palatal root of the first premolar is carious. So the infection has spread through the periapical lesion, and it has entered into it has done the palatal perforation, and it leads to formation of palatal abscess. It is vestibular abscess. It is due to infection due to central incisor. Central incisor infected. There is trauma, so it has not undergone any endodontic treatment. So the infection has spread to the periapical lesion. The infection in the periapical lesion has enlarged, and it has caused a buccal cortical perforation, and it leads to vestibular abscess. Clinically, you can see that there is vestibular abscess. Now, if you take the radiograph, you can see the periapical radiolucency in the periapical lesion. The treatment is whenever there is abscess, you have to drain. Okay, never try to give any antibiotic. Whenever there is abscess, you have to drain. Incision is drainage is the treatment of choice if there is any abscess or any pus formation is there. It is the case of submandibular space infection. You can see on the left side, submandibular space infection. There is huge swelling in the submandibular region. It may be due to lingual plate perforation from the mandibular posterior teeth. Okay. Again here, whenever there is infection, whenever there is pus, you have to drain, and you have to give the incision through the. Where will you give the incision in case of submandibular space infection? Always 2 centimeters below the lower border of the mandible to prevent the marginal mandibular nerve. And always incisions should be given in the skin crease, so aesthetically it will not be visible. It is a case of buccal space infection. As you can see, there is buccal space infection, and you must remember you should never give a stab incision over this swelling. Okay, always you have to give the incision in the healthy skin. Never directly over the lesion, because it will create large scar marks. So you have to give the incision near the lower border of the mandible in the healthy skin. Once you have given the incision in the healthy skin in the dependent part, now you have to do blunt dissection, and you can reach the area of the lesion through subcutaneously. You can use blunt instrument, either hemostat, or you can use a simple finger, and you have to dissect it, and you have to drain it. Okay. No, there are various space infections. Okay, there are various spaces. Actually, these are potential spaces. In reality, there is no any space. There is no any vacant cavity. So this is a submastoid space. It is also known as mastocytic space or submastoid space. It is present within the laterally. There is presence of masseter muscle. Medially, there is presence of lateral surface of ramus of mandible. Anteriorly, there will be basilar muscle. Okay, and posteriorly there is posterior border of ramus of mandible. And this is pterygomandibular space infection. Pterygomandibular space infection, as the name itself suggests, there is presence of medial pterygoid muscle on the medial surface. On the lateral surface, there is medial surface of ramus of mandible. Superiorly, there is lateral pterygoid muscle. Anteriorly, it will be continuous with buccal space or basilar muscle. Posteriorly, there will be pterygomasteric sling. Similarly, the space which is present just above the lateral pterygoid muscle is infratemporal space, and the space which is present just below the lateral pterygoid muscle is pterygomandibular space. So the lateral pterygoid muscle divides the infratemporal space from pterygomandibular space. Okay, this is temporalis muscle. The space which is present superficial to the temporalis muscle is known as superficial temporal space, and the space which is present below this temporalis muscle is known as deep temporal space. In reality, there is no any empty space. These all spaces are filled with loose areolar tissue. There is connective tissue. Whenever there is an infection, then it will cause a splitting of the areolar tissue, and it will lead to swelling and collection of edematous fluid and pus. So collectively, the superficial temporal space, deep temporal space, pterygomental space, and submasticator space is known as masticator space because these spaces are associated with muscles of mastication. And the characteristic feature of masticator space infection is there will be trismus. Patient could not open the mouth. So trismus is the characteristic feature of masticator space infection because whenever there is infection, it will cause irritation to the muscles of mastication. So muscles will enter into a spasm. Due to a spasm of the muscles of mastication, there will be trismus. Patient could not open their mouth. It is a case of sublingual space infection. This pus has been accumulated within the sublingual space. Sublingual space is present. The boundary are superiorly there is a presence of floor of oral mucosa. Inferiorly there is presence of mylohyoid muscle. Okay. Laterally there is lingual surface of body of mandible. Medially there is presence of sublingual gland. Next is submental space. The boundary of submental space is laterally there is presence of anterior belly of digastric muscle. These are anterior belly of digastric muscle, right side and left side. Anteriorly there is symphysis or lingual surface of anterior mandible. Posteriorly there is presence of hyoid bone. Superficially there is skin and subcutaneous tissue. In deep structure, this is a mylohyoid muscle. Okay, this is submental space. Lateral the submental space. Space from the submental space. So submental space, sublingual space, these are in pair, but there is single submental space present in the central area. In case of Ludwig's angina, the same one submental space and bilateral submental space and bilateral sublingual spaces are involved. So risk factor for infection. The risk factor for infection or space infection are uncontrolled metabolic disease like poorly controlled diabetes mellitus. So why there is chances of infection is high in case of poorly controlled diabetes? If the sugar level is high, the chances of infection is also more. What is the reason behind it? In diabetic patient, the chances of infection is more. Why? What is the reason? Because when the blood sugar level is high, there is something called as neutrophil. The function of neutrophil is to do phagocytosis. The phagocytic activity of the neutrophil is reduced. The neutrophil of phagocytes could not do any phagocytosis if the blood sugar level is high. So the chances of infection is more in case of if there is high blood sugar level. So in diabetic patient, if the blood sugar level is not controlled, then the chances of infection is high because the neutrophil could not do any phagocytosis. Another reason is on a case of alcoholism or malnutrition, end-stage renal disease. In all these cases, chances of space infection is more. Another reason is immune system suppressing disease like HIV positive patient or AIDS patient, lymphoma and leukemia, where the blood cells are produced, but they are not normal. Okay. So there is qualitative defect. Quantitatively, in case of blood cancer, the cells are produced, but all of them are abnormal. They could not function normally. So the chances of infection is again more. In case of other malignancies, congenital and acquired immunologic disease, if the patient is on immunosuppressive therapy like cancer chemotherapy, if the patient is taking corticosteroid, organ transplantation, also, if the patient has undergone renal transplant or liver transplant, they have to be under immunosuppressive drugs for lifelong. So chances for infection is again very high in such patients. Anatomic space involved in odontogenic infection. Deep facial space infection associated with any tooth are vestibular space, buccal space, or subcutaneous space. So these spaces may be involved with any tooth, whether it is maxillary tooth or mandibular, anterior or posterior tooth. On there is deep facial space infection associated with maxillary teeth are infraorbital space, or it is also known as canine space, buccal space, infratemporal space, maxillary and other paranasal sinuses, and cavernous sinus thrombosis. Cavernous sinus thrombosis is a very dangerous condition. The infection may spread from the interior region of the maxilla, and it will lead to infection to the brain. Deep facial space infection associated with mandibular teeth are space of the body of the mandible, perimandibular spaces, submandibular space infection, sublingual space infection, submental space infection, masticator space infection, submasseteric space infection, pterygomandibular space infection, superficial temporal space infection, or deep temporal space infection. Deep facial space infection of the neck are lateral pharyngeal space infection, retropharyngeal space infection, pretracheal, danger space, and prevertebral space infection. So buccal space infection, see, the infection may spread from either the maxillary tooth or mandibular tooth. Whenever there is buccal space infection, there is presence of large amount of areolar tissue or buccal fat pads, so it can hold more amount of edematous fluid, and even though there is simple infection, it will lead to huge swelling. Okay. There is this buccal space infection on the left side. Okay. Most common space infection in the maxillofacial region is buccal space infection. Buccal space infection may gets involved either due to maxillary tooth or mandibular tooth, and due to presence of large amount of loose areolar tissue and buccal fat pad, it can hold more amount of edematous fluid, and there will be huge swelling. Even in case of minor infection, there will be huge swelling in the buccal space. And whenever there is infection in the buccal space, there is accumulation in the buccal space area, you have to do incision and drainage. The incision should always be given in the healthy skin near the lower border of the mandible, in the healthy skin, and always in the dependent part. So you have to give the incision near the lower border of the mandible, and you have to drain the abscess. Whenever you give the incision, after giving the incision, you have to give the incision only in the skin. After that, you have to do blunt dissection, either using any blunt instrument, maybe hemostat or something else. And you have to remove all the pus. You have to break all the loculi. Next is sublingual space infection. Sublingual space infection can spread from the lower posterior teeth if the site of perforation, area of perforation is present above the mylohyoid muscle. So it will lead to sublingual space infection. Whenever the sublingual space infection, the tongue will be raised, the floor of the mouth will be raised, patient could not chew, there will be severe pain. In this case, again, you have to drain the abscess from intraorally. Just you have to give the incision over the floor of the mouth in the mucosa, and you have to drain it. Next is submandibular space infection. If the infection has spread through the lower posterior teeth, if the perforation is present below the mylohyoid muscle, then it will lead to submandibular space infection. And the peculiar thing about the sublingual and submandibular space infection is it is decided by the mylohyoid muscle, and the attachment of mylohyoid muscle is not fixed. Anteriorly, it is present near the lower border of the mandible. In the posterior region, it is present more superiorly near the upper border of the mandible. Right? So what happens in case of molar teeth? If there is periapical infection in the first molar area, the chances of cortical perforation is more, that it will cause perforation above the mylohyoid muscle. So it will lead to sublingual space infection. But in case of third molar, the cortical lingual plate perforation will take place below the mylohyoid muscle. So it will lead to submandibular space infection. But in case of second molar, it depends. It may either lead to sublingual space infection or submandibular space infection because the attachment of mylohyoid muscle is present more superficially or more superiorly in the posterior region. It is present just near the lower border of mandible in the interior region. It is the case of submandibular space infection. Again, if there is submandibular space infection, you have to give the incision and drainage from the submandibular approach. There is something called a danger space. It is called danger space because if the danger space is involved due to a space infection, it will lead to mediastinitis, and all the important structures are present in the mediastinum. So patient will have severe complications. There may be chances of death as well. And there are fascia. The most interior fascia is known as the buccopharyngeal fascia. After that, there is presence of the middle one is alar fascia. The space present between this buccopharyngeal fascia and alar fascia is retropharyngeal space. Retropharyngeal space is present in the posterior region, and it is separated from the lateral pharyngeal space with carotid sheath. Carotid sheath divides the lateral pharyngeal space from the retropharyngeal space. So the retropharyngeal space is present between the buccopharyngeal fascia and the alar fascia. Okay. Just posterior to alar fascia, there is presence of prevertebral fascia. And the space present between this alar fascia and prevertebral fascia is known as danger space. And from this danger space, the infection may spread to the mediastinum and it will lead to mediastinitis. Mediastinitis is a serious condition. Patient may collapse. So you have to remember is the retropharyngeal fascia or retropharyngeal space is present between the buccopharyngeal fascia and alar fascia. Just behind that, there is presence of danger space. It is bounded by alar fascia and prevertebral fascia. From the danger space, the infection may spread to the mediastinitis and it will lead to infection of the mediastinum. Now, management of space infection. So whenever there is a space infection, you have to take the history, you have to do physical examination. There may be presence of pain, swelling, carious tooth. It may be due to periodontitis or it may be due to pericoronitis of the third molar. So it may be due to odontogenic infection. Then you have to do X-ray examination, and then it will reveal either there is periapical pathosis or periodontal bone loss or there is presence of impacted tooth. Now we have to assess the severity, whether the airway is compromised or not, anatomical location where the infection is present, then rate of progression, evaluate host defenses if the patient is taking any medications, immunosuppressive medication, if there is immune compromise, systemic reserve, if the patient is immunocompromised, if the patient is taking any chemotherapy, if they are under an immunosuppressive drug, then you have to refer to a patient to the tertiary center, higher center. Otherwise, you can treat the patient in OPD. If the patient is in enucleation stage, remove the dental cause. Either you have to do extraction of hopeless teeth. If the tooth is not salvageable, non-restorable, you have to extract the teeth. If it is salvageable, then you have to do endodontic treatment and debridement, then followed by oral antibiotic, supportive care, control systemic disease, hydration, and nutrition. If it is in cellulitis or abscess stage, whenever there is pus, you have to give incision and drainage. Even if it is in the cellulitis stage, it's better to do incision and drainage, because once you give the incision and drainage, the tissue pressure will be released, so the infection will not spread. Okay, and most of the time what happens, even though there is presence of cellulitis in the surrounding tissue, the abscess is present in the center. Both of them are present together. Even though if it is cellulitis stage, just give incision and drainage. It will decrease the tissue pressure and the infection will not be spread. So whenever there is cellulitis or abscess, you have to give the incision and drainage. You have to do incision and drainage, then remove the dental cause, either do extraction or RCT or debridement. Then you have to observe if there is some improvement within 72 hours, if the temperature is decreased, there is no fever, if the swelling is decreasing, patient could open the mouth, there is less pain, then you can continue the treatment, follow up, preventive and restorative care. If within 72 hours, if there is no improvement, then again you have to refer the patient to higher center. The severity of facial infection, there is low severity, moderate severity, and high severity. Low severity, there is little threat to the airway or vital structure, like in case of vestibular abscess, buccal space infection, subparietal space infection, space of the body of the mandible, infraorbital space infection. There is, you don't have to worry. You can just give incision and drainage. You can treat the case. Okay, it will not lead to any major complications. In case of moderate severity, hindered access to the airway, like in case of perimedular space infection, submandibular, sublingual, submental, all three of them will lead to Ludwig's angina. The masticator space infection, submastic space infection, pterygomandibular, superficial temporal, deep temporal, these may cause some complications. So you have to manage accordingly. Always, whenever there is cellulitis stage or if there is pus formation, you have to do incision and drainage. You have to start the antibiotic. And in case of space infection, it's always better to give IV antibiotics rather than oral. In case of high severity, there is direct threat to the airway or vital structure, like in case of deep neck space infection, lateral pharyngeal, retropharyngeal, pretracheal space, or danger space in case of mediastinitis, intracranial infection, cavernous sinus thrombosis, brain abscess, or necrotizing fasciitis. These all have very high complication rate, and the chances of collapse is also very high. Now, cavernous sinus thrombosis. Cavernous sinus thrombosis, it is infection of cavernous sinus. Here you must understand that there are two pathways for cavernous sinus thrombosis. One is anterior path, one is posterior path. Anteriorly, infection may spread from the maxillary anterior region through the angular vein and then through the either inferior ophthalmic vein or superior ophthalmic vein. The pathway is through the If there is infection in the maxillary anterior region, infection will travel through this vein, the angular vein. From the angular vein, either it will enter into the inferior ophthalmic vein or superior ophthalmic vein. Either through the inferior superior ophthalmic vein, the infection will reach to the cavernous sinus. Okay. Another pathway is through the posterior pathway. Posterior pathway is through the pterygoid venous plexus, because the pterygoid venous plexus is connected to the cavernous sinus through the emissary vein. So whenever there is infection in the pterygoid venous plexus, this pterygoid plexus, the infection will travel to the cavernous sinus and it will lead to cavernous sinus thrombosis. So you must understand that for cavernous sinus thrombosis or cavernous sinus infection, there are two pathways. One is anterior pathway and another is posterior pathway. Under anterior pathway is through the from the maxillary anterior region, infection will spread into the angular vein. Then through the angular vein, either through the superior ophthalmic vein or inferior ophthalmic vein, the infection will be transmitted to the cavernous sinus. In the posterior pathway, the infection from the posterior area will enter into the pterygoid venous plexus. As you know, the pterygoid venous plexus is present in the infratemporal region. Whenever you give the posterior superior nerve block, PSA nerve block, the chances of pterygoid venous plexus rupture is very high. So once the pterygoid venous plexus is infected, the infection will transmitted to the cavernous sinus. These are the through the emissary vein. This is posterior pathway. Even the cavernous sinus thrombosis is very dangerous. It may lead to death of patient. In case of cavernous sinus thrombosis, just adjacent to cavernous sinus thrombosis, there is presence of internal carotid artery, abducent nerve, as well as there is presence of maxillary mandibular division nerve, as well as there is presence of third cranial nerve, oculomotor, trochlear. So all of these nerves can get infected, and the function of this nerve will be compromised. Okay, there is presence of bilateral cavernous sinus. There is presence of pituitary gland in the center. The nerve are present adjacent to this cavernous sinus. So whenever there is cavernous sinus thrombosis, it will lead to infection of the adjacent nerve as well. So the oculomotor, trochlear, all three branches of trigeminal nerve may also be involved. And most commonly, you can see the complication of cavernous sinus thrombosis in the extraocular muscles within the eye. So clinical features are nervous system, severe pain in eye and forehead. So because there is involvement of third, fourth, and sixth cranial nerve, oculomotor, trochlear, and abducent nerve, because all these three nerves supply the extraocular muscles. Okay. So venous symptoms will be there will be edema of eyelid, exophthalmos, proptosis, and retinal hemorrhage. Diagnosis of cavernous sinus thrombosis is done based on Eagleton's criteria. There are 6 criteria. So if all of them are present, then it is considered as there is presence of cavernous sinus thrombosis. There must be known site of infection, either infection in the maxillary anterior region or posterior region. Evidence of bloodstream infection. If you do the blood culture, it must be positive. Early signs of venous obstruction of retinal vein of unaffected eye. Paresis of third, fourth, and sixth cranial nerves resulting in inflammatory edema. The extraocular muscles are involved, so their patient could not rotate their eyeball. Abscess formation in the neighboring tissue and evidence of meningeal irritation. In case of meningeal irritation, the patient could not bend their neck. Corneal sign will be positive. Okay. It is the case of cavernous sinus thrombosis. As you can see, there is inflammatory edema present with around the eye. The buccal space is also involved. There is abscess, there is swelling over the forehead. The same patients after treatment. So you have to do lab investigation. You have to see the blood chemistry, complete blood cell count, clotting profile, particularly important patient who requires surgical drainage. Blood culture may be indicated in septic patient. Abscess culture with gram stain critical to direct antimicrobial therapy. Whenever you are prescribing antibiotic, always it's better to do culture and sensitivity. You have to send the post to microbiology lab. They will do culture and sensitivity, and depending on the sensitivity, you have to prescribe the antibiotic, because you don't know which antibiotic is sensitive to which bacteria or whether it is resistant. So make habit of doing culture and sensitivity. Whenever you find a post, send it to laboratory for culture and sensitivity, and depending on the sensitivity, you have to prescribe the antibiotic accordingly. Radiological examination. In conventional radiograph, you can do either intraoral periapical radiograph, OPG or lateral oblique view of the mandible, or EP view or lateral view of the neck for soft tissue. Other diagnostic aid can be, you can do either CT scan or MRI or sometimes nuclear medicine also. Goals of management of facial space infection are airway protection, surgical drainage, medical support of the patient, identification of etiologic bacteria, and selection of appropriate antibiotic therapy. Okay, we'll continue tomorrow.